My name is Amarachi Okereke, and today I will be performing a newborn exam for my course, Newborn, which has the code MDW 141. My instructor is Larissa Plett-Hill. First, before I start the newborn exam, I will allow the mother and baby to have their golden hour. This is an hour or so after birth, where the mother and the baby are able to bond. During this time, the baby will have skin-to-skin contact with the mom. This will help the baby retain warmth, bond more with the mother, and also calms the baby down. So by the time it's time for me to do the newborn exam, the baby's not fussy. Because a lot of times, babies, when you take them away from their mom, they're a little fussy. So if you can get them calm and have a nice, warm atmosphere around them, it makes it easier to do the exam. Before I do the exam, I make sure I have all my equipment. So I have my list for my newborn exam. This just helps me in case I miss anything. I've got my measuring tape. I've got my hanging sling to weigh the baby. I have a box of gloves. We're gonna pretend I have a box of gloves here. And I have a stethoscope around my neck. Before I start, I'm gonna inform the parents of what I'm going to do. I'm gonna ask them if this is a good time, and I'm gonna ask them if it's okay for me to do this exam. All right, so it's been a little over an hour. You and baby seem to be bonding really, really well. Would it be okay if I start the newborn exam now? What's the newborn exam? So the newborn exam is when I do a head-to-toe assessment on your baby, just to make sure that everything is normal and all the extremities are fine and that there are no abnormalities or things that we need to refer to the pediatrician. I do it right here. You and Dad can watch as I do it and ask questions if you have any questions. Would that be okay? If you don't want to, we can always push it off for a little later. It's okay to do now? Thank you so much. Whenever you're ready, I'd love to hold your baby and then I'll be able to do the exam. Thank you so much. I'll get the baby. Now, before I start the exam, when I get the baby, I'm going to coo at the baby and I'm going to be very kind, gentle, and make little calming sounds. Babies may not be able to understand us or speak our language, but they do understand a comforting touch and they understand a gentle sound. So the baby might be a little fussy when you separate the baby from the mom. So I would do things like this. Hello. Oh my goodness. Oh my goodness gracious. You are so beautiful. Wow. And then I would do things like include the parents. Your baby's so precious. Oh, she's a beautiful baby girl. She looks like you. Okay, let's get this newborn exam started. While I'm cooing, I'm also looking at the baby and seeing if there's anything of note so far. There is nothing of note. While I'm going to examine the baby, I'll try to keep the baby as covered as possible to keep the baby as warm as possible. But underneath the baby, there's going to be a heating pad to keep the baby warm as well. Ideally, whatever I'm not looking at, I want covered. Unfortunately for the baby, one of the first things I have to look at is skin, so I am going to have to unwrap the baby very soon. So first, I'm going to look at the baby's state of awareness. So in this scenario, the baby cried a little bit when I took the baby away from mom, which is good. So the baby had a good cry. In this scenario, the baby's kind of stretching and trying to kind of kick its way out of the wrapping that they gave me. So good state of cry. I don't see any jitteriness or tremors, so that's good. Now I unfortunately have to unwrap the baby. So the baby might be a little cold, but there's a heating pad underneath. I don't think I mentioned it, but I would have put on gloves by now. So my first pair of gloves are on. I'm so sorry that I didn't mention that. So I will look at the baby's skin and I will hold the baby. Just like this. Right now the baby is all pink. Condition looks good. I don't see any lanugo on the baby, which is good because this baby is term. Whenever you see me holding the baby to see the baby's back, what I'm doing is I'm supporting the side of the baby's face here and I'm putting my thumb under the chin. I'm not putting my hands on the baby's neck because that might choke the baby. I'm just gonna go like that and look like this. Okay, Skin is looking good. Like I said, no lanugo, no milia, no stork bites. There is some vernix on the baby. And so what you can do is just, if there's vernix on the creases, I would just rub a little bit, just rub it in so that it doesn't, stay there and get gunky. But if there's vernix anywhere else outside of the creases, I wouldn't rub it, I would just leave it like that. So far, skin is good. Next, I would wrap the baby up again. Like I said, I want to keep the baby as warm as possible. And now we can do our head to toe assessment. I try to do little check-ins with the mom and dad as well. So far baby skin is looking so good and healthy, and that baby has that nice healthy vernix that's really good. It helps with moisturization for the baby, and it's just a good kind of protectant for the baby's skin. I'll lift the baby up again, and I'll start with the head. So far, I don't see any bruising on the baby's head. That's very good. I would now feel with my hands just here, and I would support the baby with my arms underneath the baby, and I would just feel around the baby's head. There is some slight molding that the baby has, but it's gone down because we've given that baby that golden hour, so it's gone down a little bit. And there's no sutures overriding, there are no sutures separating, there is no caput, there's no cephalohematoma. Okay, and now I'm gonna look for fontanelles. I see the anterior fontanelle, and it is still open, and the posterior fontanelle. It is also still open. So that's good. If they have any questions, such as if the open fontanelles are safe, now's a good time to answer those. Yes, it's totally normal. So these will close. Remember that the baby's bones are very fragile and very thin. They're not sturdy like our bones. And remember, the baby's brain is still growing. So the brain has to have space to grow, which is why the bones are so soft and why the fontanelles are still open. They will naturally close on their own. So don't worry. You don't have to press it down or anything like that. Alrighty. So we've done the head. Head is good. Now I'm gonna move down to the ears. So I'm gonna look at the baby's ears. Once again, trying to keep the baby as covered as possible. I would note that these ears appear patent. I say appear because I really have no way of knowing for sure that they're patent. However, I do see a clear ear canal with no obstruction. The ears are also even and symmetrical. I know this because the top of the ear matches the line on the eye. Great. Now let's check the eyes. On this model, the eyes aren't open, but let's pretend that the baby's eyes are open. The baby's blinking, so that shows me that the baby has their blinking reflex, which is fabulous. The baby's also reacting to the lights around it. The pupils are even, equal, and dilated. And I would take my finger and move from left to right, and the baby's following it. I would also make note that the eyelids do not show any signs of edema, and the white sclera, or the sclera, is white. So eyes are good. Once again, quick check-in with the parents. Ears and eyes are good, mom and dad. So far, so good. Next, I would go to the nose. Now, I'm going to do the nose and the mouth together because to check for nasal patency, you can use the mouth exam. So now, I'm going to take off these gloves because I've been touching the baby's body this whole time with my gloves. And so once I start doing the mouth exam, I'll have to put one finger into the baby's mouth. I don't want to get any of the mucus or liquid from the mother that's on baby into baby's mouth. That can make baby sick, that can bring infection. It's just not a fun time. So these are my old gloves. I just tossed them, and there's a garbage here, so I'll toss it there. And I'm gonna put on some new gloves, okay? Now, this is the hand I'm gonna use to put in the baby's mouth. I'm gonna keep it high up so I don't accidentally touch anything. I'm gonna use this hand and get the baby up. Let's do the mouth exam, and then we'll also do the nose exam to test patency. So I'm gonna take my pinky finger, and I'm gonna put my finger upside down like this, into the baby's mouth. I'm going to feel the baby's palate. Palate is closed. I'm going to go deeper in and feel the baby's upper maxillary area, also closed. And at this point, the baby should be sucking. So that shows me that the baby has a good root and suck reflex. What I'm going to do now is rest the baby's head down. There should be a cushion underneath the heating pad. And what I'm going to do is I'm going to close one nose to check for patency. Close one nair. At this point, the baby should struggle a little bit. That's a good sign. And close the other nair. At this point, the baby should struggle a little bit. That's a good sign of patency. So we know that the baby has good sucking, that the baby has an intact palate and an intact upper maxillary area. We also know that the baby's nose is patent. Really quickly, I'm going to check for lip and tongue ties. All right, so I'm going to look here. The baby appears to not have any lip ties, Then I'm going to go under the baby's tongue. The baby does not appear to have any tongue ties. Now's a good time to turn to the parents and explain what you're doing and what that means. So your baby doesn't appear to have any tongue ties or lip ties. These are when the little frenulums here and here under your tongue, when they're too big, and so they actually affect the baby's ability to feed. So right now I don't feel any problems, but if the baby's having any problems latching on later on, or sucking, or you're hearing any clicking when the baby sucks, please let me know and I can give you contacts to a lactation specialist. Now's also a good time to explain what you're doing with the nose, if you didn't explain earlier. Also, I hope you didn't think that I was hurting your baby. I was just checking for patency. If the baby struggles when I close one nostril, while I have the finger in the baby's mouth, that means that the baby was using that nostril for air. It lets me know that both passages are open. You're done with the mouth exam. Now let's wrap up the nose exam. So we already checked for patency. Now we're going to look at the nose. Everything seems to be even and symmetrical. So we're done with the nose. Now we're going to check the neck. We're going to check for range of movement. So I'm going to brace the baby's head like this and turn the baby's head left to right. Good. I don't feel any resistance or hear any clicking. Good. Good range of movement for the neck. Let's check the clavicles. I'm going to lay the baby down gently. Try to cover the baby as much as I can. And I'm just going to feel. The clavicles feel smooth and even, and they are also symmetrical. So the baby's clavicles are good. Next, I'm going to go to the arms and hands. So, to test this, I'm going to pull the baby's arm. Ideally, if I pull the baby's arm, the baby should yank their arm back. And in this case, the baby did. That's very good muscle tone. I'm now going to check the baby's range of movements just by rotating the arm backwards and forwards. I don't hear any clicks, and I think we have a good range of movement. I'm also going to bend at the elbows forward and back, forward, and then up. Good range of movement on the arms. Now let's check the hands. So first and foremost, I'm going to look at the creases of the hands. This baby is 40 weeks gestation. So this baby has many creases on the palms of the hands to show maturity. So that's very good. Another thing we're going to do is check the palmar grasp. I'm going to put my fingers on the baby's palm, and the baby's palm should curl over my thumb. So we know that their palmar reflex is perfectly fine. So far, so good. Tuck the baby in again. Keep the baby as warm as possible. All right, now we're gonna listen for sounds. First, we're gonna listen to respiration quality. Then we'll count the respirations. Then we'll do heart rate. Then we'll check bowel sounds. All right. Well, I'm so sorry. Visually, I'd like to look at the abdomen first. So, visually, the ribs seem to be symmetrical and even. I'm now going to feel to make sure that that's true. It's true. There doesn't seem to be any issues, and baby does not seem to be in any pain when I gently press, so that's good. I'm now going to feel breast buds. Baby's breast buds appear to be fully developed for gestational age and within normal limits. Now I'm going to feel for masses. There don't appear to be any masses in the abdomen. Now we can start listening for things. I'm going to take my stethoscope, put them in my ears, and I'm going to go to all 4 lobes of the lungs to check for lung quality. You can stay about 10 seconds on each lobe just to check lung quality or respiration quality. Lung sounds are clear. Now let's count the respirations. There are 3 ways that you can count respirations. You can put your stethoscope on the lungs and you'll hear the breathing of the baby. It'll sound kind of like as if air is kind of going through a tunnel, which it kind of is, right? So that's one way. Another way, sometimes the baby is moving around and crying and fussing, and it can be hard to hear the baby's lung sounds simply with stethoscope. At that point, you can let the baby's chest rise and fall and count. And then the third way, and a way that's personally my favorite, is to put your hand on the baby's belly. A lot of babies, when they're first born, are mouth breathers in a way, and so when they breathe, it's very exaggerated on their belly. So you can feel the rise and fall of their belly and count those respiration rates. But for this example, I'll be using my stethoscope. The ideal respiration range will be 30 to 60 breaths per minute. I'm going to put my stethoscope just on any lobe. I always like to do the upper right lobe for the baby, and I just listen. Now, in this scenario, we're going to pretend that I did it for a minute. But if you have a baby that's very fussy and you're only able to get 10 seconds, 15 seconds, or 30 seconds, you can still work with that. If you get 10 seconds, you can take that number and multiply it by 6. If you get 15 seconds, multiply it by 4. If you get 30 seconds, multiply it by 2. In this scenario, I got a respiration rate of 45, which is good for the baby. Next, I will do the heart rate. Heart rate's a bit easier because it's right there and you can't miss it. Well, if the baby's not screaming and fussing, you can't miss it. I'm now going to take my stethoscope and put it central, but a little bit to the baby's left, right where the heart would be. I apologize for the noise outside. And I'm going to listen for a minute. Once again, if you're not able to get a full minute, you can do the multiplication that I just told you before. 10 seconds multiplied by 6, 15 seconds multiplied by 4, and 30 seconds multiplied by 2. This baby's heart range is 152, and that's wonderful. So we can move on to bowel sounds. The baby appears to have normal bowel sounds, and everything seems to be functioning. It's been a while since we've checked in with the parents, so now would be a really good time. Baby's doing really well. Heart rate's great, respiration's great, and bowel sounds are amazing. So now we can go to the lower part of the baby. Like I said, always try to keep the baby wrapped up. Okay, so now I'm actually going to check the legs. I'm going to do the same thing. I'm going to pull the baby's leg, and if the baby yanks their leg away from me, that's really good. So the baby yanked their leg away from me, very good muscle tone. And now we are going to check the baby's range of motion. So we want to make sure that the baby doesn't have any hip clicks and that the pelvis is in place and that nothing is popping out of the sockets. So I'm going to take my hands, I'm going to open it just so the camera can see what I'm doing. I'm going to take my hands and kind of put them near the baby's hips like this. The baby's going to start with their legs abducted. I am now going to push the baby's legs gently into the bed and then adduct them this way. That is a Barlow's maneuver. Now let's try Ortolani. Ortolani, I'm gonna pull towards me and push back. So I didn't hear any clicking and I didn't feel any sockets coming out, so the baby's range of movement is very good. Next, what I'm going to do is check the baby's feet. First of all, the creases are all appropriate for gestational age. A lot of lines and creases showing that the baby is fully matured. So we have lines and creases going all the way near the bottom of the foot. Next, I'm going to check the Babinski's reflex. I'm going to drag my fingers along both soles of the baby's feet, and the baby's toes should flare out like that, just like how this toe is. Next, I'm going to check their plantar grasp. I'll put my thumb underneath the baby's toes, and the baby should curl their toes over my thumb. Awesome. I'm also going to look at the toes and count them. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. All toes seem to be of a normal shape, and there's a normal spacing, and there's no webbing. If you forgot to do the fingers last time, if you forgot to do the fingers while you were evaluating the arms, like I just did, this is a very good reminder to go back and check the hands. So I did all the maneuvers on the hands, or rather I checked the reflexes on the hands, but I didn't count and I didn't check for taper. But it's not too late, I can still do that now. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. All fingers are good. They all have a normal shape and taper, and no webbing. Another thing I forgot to check was retractions. I don't see any retractions. The baby is not grunting. And when I listened, I didn't hear any rallies or rhonchi. The baby also did not have any abnormal cry. So we are good with the abdomen. The only thing we have left to do, the only two things we have left to do are the genitals and the umbilical cord. Let me edit that, I'm so sorry. The only things we have left to do on the front of the baby are the genitals and the umbilical cord. So I'm just going to look at the genitals very quickly. This is a baby girl. So baby girls are really easy. They're easy because there's not something that you have to, hold on to. You just have to take your gloved hands and you're just gonna gently spread the baby apart so that you can see that the urethra is in normal position, that the vaginal orifice is in normal position, and that the baby's labia is also in normal position. This baby is completely healthy. Lastly, you're gonna look at the umbilical cord, and this will be a good time to check in with mom and dad. Umbilical cord looks good, and if you look at the tip of the cord, you can see that there are 3 vessels, 2 arteries, 1 vein. Now's a good time to advise mom and dad about how to take care of the umbilical cord. This is the baby's umbilical cord. It's really good that you leave it alone and just let it air dry. You don't have to put alcohol or creams or anything on it. In fact, when you're putting a diaper on the baby, it's really good to fold the diaper underneath the umbilical cord so that the umbilical cord can dry out. Okay? Awesome. We're almost done with the exam, and then we'll get to the fun stuff like weighing the baby. Make sure to have your guesses in. Okay. So now, we're gonna flip the baby over, just like how I told you before. I'll use one hand to support the baby's face, the other hand to support the baby's chin. I'm gonna flip the baby over like this, and we're gonna look at the baby's spine. The baby's spine is straight and symmetrical. There are no dimples, no sacral dimples, which could be indicative of MTFR. The baby's anus there are no anal fissures. The baby's anus is in a normal location, and it is patent. I know it's patent because the baby has already passed meconium. So I believe that's all for the back. This is why it's good to have a list next to you. So I'm going to double check that I have everything done for the back. See, one more thing. I see no Mongolian spot. Now, Mongolian spots are also called slate gray nevi. I do not see a slate gray nevus or a Mongolian spot, so baby's good there. The last 2 things I have to check before we can get to measuring the baby will be the baby's moral reflex and stepping. For me to check the moral reflex, I like to do a little bit of a drop. So I'm gonna hold the baby like this, and then doop, that's it. And if I do this, I don't like to go too hard. I don't wanna scare the baby or scare the parents. So I just like to do a little doop, and usually their hands will come out and splay out and startle like that, so they have their moro. Last is the big step. So I'm gonna hold the baby like this. You let them float a little bit. You let one foot touch the ground, and then the other should make a big step. And now we've done everything we need to do for the baby, head to toe assessment. Now we can go and do measurements. To measure the baby's head, firstly, I will be measuring in inches because I live in the United States. You're gonna lift the baby's head up and go from the back of the head all the way around, and it should end just right above the baby's eyebrow. Okay, I got the baby's head measurement as 13 inches. Good. Next, we're gonna measure the baby's chest. Always support the baby's head whenever you're moving the baby. You want to measure just at the breast line for the chest. Okay. For the baby's chest, I have 11 and a half inches. Good. So the baby's chest is smaller than the head. That's very good. That means the baby is not barrel chested. And then I'm also going to measure the baby's abdomen. This is just standard practice at the birth center that I'm at, so that is why I'm doing it, but not all places require all three measurements. Just get the baby's abdomen, and the baby's abdomen is 11.75 inches. Okay, and then the fun part. This is a really good time to involve all the family. All right, guys, it's time to weigh the baby. Do we have any guesses? 6? I don't think this baby's 6. This baby looks a little bigger than 6. What do you think? What do you think, Dad? 9? Oh gosh, that's pretty big. I don't know about that. What about you, Grandma? 7.8. Okay, I was thinking 7.4. Let's see what the baby weighs. Before you do the measurement, if you're using a tear counter, you want to zero it out, or sorry, not a tear counter. Before you use your hanging scale, you want to zero it out, and then zero it out with the blanket on there so it doesn't count the blanket. Then you can take the baby and put the baby right here. Babies tend to like this because it's nice and cozy. And now you can weigh the baby. Usually you'd let the dad do this, but for this example, I'll be doing it. All right, we have 7.7. Grandma wins. You know, grandmas know it all. They know everything. You play around with the family a little bit. Everybody's happy. Everyone's having a good time. You put the baby back down wherever the baby was wrapped. And then, for efficacy's sake, you check your list and make sure that you did everything you needed to do. Okay, there's one thing that I forgot to do, which is a good reason why we check. I forgot to check the different pulses. So, I will now check the brachial pulse. Good beat, I can feel it. The femoral pulses. And the temporal pulses. All right, perfect. We'll wrap baby up and we'll hand baby back to mom and dad. And remember to thank them for allowing you to intervene on their time to do this exam. Thank you so much. Here's your beautiful baby, nice and healthy.